Yeah, just one question, Dr. Madhvi, just for your understanding. If we are going to discard that zone, which is the contralateral zone, in all cases, then why dissect it at all?
Sir, we need to have. We cannot leave it.
Why?
We need to exercise it to
Simple logic.
anyways close the abdomen, sir. We cannot leave it there. We cannot. So that has to
So
be
this is an
resected out.
elliptical excision. So you have to take it out as an elliptical excision and then discard so that you can get a good closure. Yeah.
Yes, sir. Yes, sir.
Yeah.
It's for cosmesis, right? That's why we're doing it.
Sir? Pardon,
It's for
sir?
cosmesis.
Yes,
It's
sir.
basically an abdominoplasty that you're giving the patient.
Yes, sir. Yes, sir. Uh,
Go on, go on.
my insight would be based on the footprint, the conus, and the envelope reconstruction. As far as the footprint is concerned, the footprint is the part of the breast, posterior wall of the breast that is adherent or that is based on the pectoral fascia, and that is determined by the upper by the intramammary fold inferiorly and the upper pole of the breast that roughly corresponds to the footprint. My initial during inset, the first stitch would be laterally at the pectoral fascia just below the tendon, where I will tag the lateral end of my flap to the pectoral fascia, and then I'll insert it along my footprint and along the along the excised margins, maintaining a lazy S contour, and near the mid clavicular line my second key stitch will be given, and I will also have bunching up of the flap over here in order to provide some volume to the inferomedial quadrant. I will also do a wedge excision of the uh, part of the flap that is corresponding to the umbilicus, and I will suture it to that gives more projection. And my last key stitch will be medially. At this point, I will decide what to deepithelize, which to remove, and that part will be anchored immediately onto the fascia. And then the conus will be the flap will be uh, closed, and the superior skin flap of the chest wall. Oh, yeah. Yeah, the superior the where am I? Yeah, the superior skin flap will cover the deepithelized portion of the DF flap, giving the contour and the envelope to the breast. Sir, along with this, in this same sitting, I would like to do even an contralateral.
Now, maybe
Breast.
before going on to that, there are a few things. Okay, now you have inset the flap, you have, anastomosed the vessels, right?
Yes,
Now,
sir. Yes,
a
sir.
couple of things. How do you decide the size of your skin paddle? How much are you going to deepithelize and how much skin you're going to? I presume you're going to have a skin paddle, right?
Yes, sir.
Right. How
Mm,
would you decide that?
uh, that will be determined by the uh,
Would you determine that pre-op or would you determine on table?
it will be decided on table, sir. Pre-op, and it is an elliptical incision,
So
so
how
that
are you
whole
going to?
thing.
You want to match it to something? You got to have certain. You would be having certain, measurements to match up to.
Um,
That's something you decide pre-op, right?
yes, sir.
So, how do you decide that? How much skin paddle to have? Because you got to then decide your de-epithelializing accordingly, right?
Yes, sir.
So,
Sir, that will depend upon the once I have deepithelized the inferior skin paddle up to my proposed intramammary line, and I have raised the what is this superior skin paddle. I'll be able to assess approximately how much of skin paddle I would require, and how much of it can be deepithelialized?
But on what basis? Just the amount of skin you got from the abdominal part, or there is some other criteria?
Sir, I'm not sure, sir.
Right. Okay. Yeah. There's sort of one aspect which you have missed in the beginning is to first take into consideration patient requirements, patient expectations. Right. And that's after that's the second part of your assessment or pre-op consultation as to what the patient wants.
Yes,
Right.
sir.
Our size expectation, we can't go by just what we want to give.
Yes,
Please
sir.
to decide what they want or what the patient wants.
Yes,
So
sir.
you have a discussion as to what the volume they want, and that also then decides which reconstructive option you end up choosing, and that also decides whether you want to address the contralateral breast or not, right?
Okay, sir. Yes,
So
sir.
if you have a case where she says don't touch my contralateral breast, then your skin pattern is going to be different, right?
Yes, sir.
If she's allowing you to reduce the opposite side, then your skin pattern will be different, right?
Oh,
So all
yes, yes.
pre-decided. That is not decided on table.
Okay, sir.
Okay.
Okay, sir.
That is a very important question, Madhvi, because yeah, sometimes a flap itself would be a different flap. Maybe if you want a really small breast, maybe you would have just taken a LD and a pedicle LD and just put instead
That's
of
what
microsurgery.
that's what I'm getting to. So now we presume that, for argument's sake, that she does not want you to touch the opposite breast.
Okay, sir.
She's had enough
Okay.
problems on one side. I want to limit everything to one side. So please do whatever you want to do on one side only. So now you
And then
obviously want the biggest flap available. So which is the biggest flap you can give her?
DF would be a biggest.
Right.
yeah,
Right?
Yes.
right.
So then you
So
want to be as focused on the zones as possible, right? You don't want
Yes,
to very, predeterminedly discard. You want to see perforation, you want to see perfusion. Sorry, you want to see perfusion before you start discarding the marginal zone.
yes, sir.
Right.
Okay.
So in case you want to retain that contralateral outside zone, what else can you do if you want a large breast? What is there anything else you
Okay.
can do, Dr. Madhvi?
Yeah, that's a bonus question.
Um. Uh.
See, considering you're considering microsurgery as the first option, you got to be ready for this. You're basically working in a tertiary center, or you're a very expert to high level. So you got to know that.
Is there any way you can retain that zone which otherwise you would discard because the patient has a opposite side large breast which she does not want you to touch? Is there
Okay,
any
sir.
way you can help her with this? Microsurgically, is there any way you can help her with this? Is there any way you can increase the perfusion to that opposite side
Sir.
lateral part?
Yes, sir. I could supercharge the
Yes.
flap
Very good, very
in the
good.
opposite side vessel, or
Exactly.
yeah, and supercharge the flap so that all quadrants are equally.
Correct. Correct.
How to
Yes.
supercharge it?
Right? So that is what you would do if you had to use the full, yeah, and you did not have to touch the opposite side.
Yes, sir.
Right? Now let's talk
Yes.
about the other options we have, because it's a short case, so we can't take it for too long. We got other 4 cases to discuss.
Right, right. Yeah.
So now you tell me what are your other options? A, if you do not have, this is your gold standard for microsurgical reconstruction, right? Now, if you do
Yes.
not have access to microsurgery, then what would be your plan option?
Uh, in case of my, if I don't have microsurgical, in order to provide a similarly large breast, I would like to take a tram pedicle tram flap.
Right?
Um, um, but I would warn her of the possible complications with it. Mm, uh,
Everything has got complications. We'll come to that in a minute about
yes, sir.
complications. Yeah. So that is, yeah, a pedicle tram, right?
Yes, sir.
Okay. And would you place it vertically or horizontally?
So the pedicle tram would be placed vertically, sir. Thus the zone 3 comes above and zone 1 comes below, forming the skin paddle.
Right. Okay. Fine. What other option do you have?
Other than this, uh, Other than this, there is a pedicle LD flap with an implant. Um,
Right.
um,
What would you do in that?
Sir, in that case, um, since this is 9 months since the time of sorry, it has been 1 year since the procedure has been done. I may not get such a very compliant place for area to put my implant in. So I would like to take an LD flap, place it, and also put an expander, expand
So
and
would you take
activate the space
would you
chamber.
take a LD muscle flap or musculocutaneous flap?
Sorry, sir. LD musculocutaneous flap, sir.
Yeah, so you got to be specific, right?
Yes, sorry, sir. Yes.
That you yeah. How do you decide the size of the skin paddle in that case?
The skin paddle will be the length will be equivalent to the length of the scar or the around 30 centimeters, and the width would be um, will be decided as to how much we will be according to the amount of skin we can excise. No, sorry, sir. The length will be equal to the length of the scar, and the width will
Which
be
will be
uh,
see
such that I'll be able to have achieve a primary closure.
primary closure.
Correct, perfect. Yeah, so
Yes.
you do that now, but you got a significant amount of breast to match up to the opposite side. So obviously not going to get enough, right?
No, sir.
So
So,
what would you do? How would you then try and match up?
sir, pardon, sir. How would you?
Yeah,
So,
you would not get enough skin, right? Even
Yes,
though
sir.
whatever maximal you try, you would not
Yes.
get enough skin. So how would you try and match up to the opposite breast?
Yes, sir. I would, in addition to this LD mycelium slab, I would like to put an implant beneath it to provide the volume.
Okay,
But in this case, since it is a 1 year gap has is there, I would like to first provide some expansion and
correct.
then
So yeah,
and
so
apply put
in answer in a short case would be I would put a LD myocutin flap with tissue expander, right? Which will be
yes, sir.
subsequently replaced with a permanent implant. All right.
Yes,
So that will save asking so many questions, right?
yes, sir.
Yeah. So that is yeah. That would be a good. Okay. Now we go on to in case she is okay with you addressing the contralateral breast, then what would you consider in that?
So in case of the contralateral breast, I would like to go ahead with the inverted T-scar technique of mastopexy, where after making the markings, I would like to
What is the aim
ex-
of this procedure? What is the aim of this procedure?
it is to uh, uh, it is to reduce the ptosis of the contralateral breast.
Reduce the ptosis or reduce the size?
Sorry, sir, reduce the size. So it will be a
Reduce the
reduction
correct, correct.
reduction mastectomy. Sorry, sir.
Yeah. Okay. And
Reduction mas-
every reduction has a mastopexy element to it, right? So you don't need to mention it separately. Okay.
Yes, sir. Yes,
Yeah.
sir.
Okay. So you would consider yeah inverted T mastopexy. All right. Okay. Reduction. Okay. Go
Yes,
on.
sir. Sir?
Now, yeah, that's fine. Now, anything else you want to tell in brief?
Other than this, I would like in future I would like to do a nipple areola reconstruction
Okay.
using the what is this, a skate flap
Mm-hmm.
or a double opposing um, skate flap, so
Right.
that there will be and also that's it. So
And for the areola,
areola. Uh, uh, if it is a skate flap, then the areola will obviously be covered by that area which will be grafted. So that
correct.
will give somewhat of the thing.
That's right. Okay, that's good. Now tell me how would you monitor your DF flap if you do a free flap?
Sir, in the first,
Intraoperatively, immediate post-op, quickly, very fast.
yes, sir. It will be every hour in the first um, every hourly in the first 24 hours,
How would
followed
you
by.
monitor?
Sir?
How would you monitor?
What would you
Uh,
monitor? What would you monitor? What
Basically, I would monitor the color, the temperature of the flap, and also I would assess with the pinprick bleed, and also with the Doppler, um, handheld Doppler to assess for the arterial and venous signal and the spread of the signal.
So would you put it on your anastomosis at the intramammary, the mammary vessel as a routine?
Sir, I would put the Doppler on the flap and assess for the. I'm sorry, sir. I didn't get your last question, sir.
No, no.
Did,
What is your routine monitoring for the flap? Is the Doppler a routine thing you do?
so we routinely monitor with the Doppler, sir, in our
At what
institution.
point?
Up to um
Where do you
up,
Doppler?
sir, I will monitor in the distalmost part of the flap to look for the perfusion.
And you get a signal there?
Sir?
Okay. Yeah, yeah. Go on. What are the complications we can expect?
Sir, I would expect some partial necrosis, probably, and also some amount of um, immediately partial necrosis of the flap is one complication. Then wound site infection and
commonest problem after a free flap, Dr. Madhuri? Immediately in the first 24 hours,
Immediately.
what
You
is the
got to tell
common
an order of commonality.
what's
order
the
of some
commonest problem in the free flap after in the first 24 hours?
congestion, congestion, sir. Congestion. So, um, uh,
How will you make out that there is venous congestion?
mainly the color change and the mm,
So what
the
happens
when there's on pin.
precisely? No, color change means what? Does it become white? Does it become white, the color?
Sir, in term, it tends to become a little um,
Dark, no?
congested.
Dark. Congested is dark, no?
Yes, sir.
And what else?
There will be a brisk bleed and a venous bleed on pricking, and we may not get a venous
Venous
signal.
bleed. What is venous bleed? There are no veins bleeding.
Sorry,
What is
sorry,
venous?
sir. There will be a dark
Yes. So
red or
yeah, that's what
bleeds.
you have to come out with. Yeah, there shouldn't be follow-up questions. They should be,
Yeah.
yeah, it is congested with a dark venous bleed. The blood is dark in color. That is, and it does not stop. It keeps oozing because of the congestion. So
Yeah, correct.
Sorry,
So
sir.
whether it's arterial blockage or venous blockage, by the color you decide that. Okay, and you plan accordingly. If the arterial block, you'll get all white, right?
Yes,
And
sir.
pale colored. And if it is congested, then it is a venous block, right? So you address
Yes.
accordingly. So that's what you're monitoring. That's what you want to know very quickly because it's a short case. When I say complications, you start saying 1 to 10 in order of. And what is the commonest complication, Dr. Millen asked?
Congestion.
Congestion is a symptom. I mean, congestion is not a com. Yeah, I mean, that you call
Venous
venous or
thrombosis.
arterial, yeah, hematoma.
Yes, sir. Thrombosis and venous thrombosis. And there is flap necrosis. Then
Okay.
further wounded.
Madhavi, sorry to interrupt you.
Yes, sir.
Madhavi, when you are asked, as Sandeep sir has asked you, you have to tell the complications, early complications and late complications like that, starting from the time of anastomosis. Okay,
Yes, sir.
that way you should rattle out.
Right. So now just to wind up this case, tell me what is how do you define breast conservation surgery?
Um,
What is breast conservation surgery?
Breast conservation surgery is wherein it is the excision of only the uh, um, of the tumor while sparing the rest of the breast.
Right. Just limited to what the pathology.
Limited lumpectomy
Yeah,
and
right.
yes, sir.
Lumpectomy and segmental, all that is breast conservation, so, right?
Breast conservation, sir.
Mastectomies and all. So wherever you're limiting the amount of resection to the pathology. And what is
Yes.
oncoplastic surgery? Because nowadays everybody refers to as oncoplastic breast surgery. What is that?
It is the use of reduction mammoplasty and reduction mammoplasty techniques to the oncological excision of the tumor and reconstruction, sir. For these are mainly applicable for T1, T2 tumors, which are localized to
Correct.
part of the breast. So where
Very
that
good.
part,
Yeah.
yes, sir. That part of the
Go
yes,
on.
sir. That part of the tumor is excised, and using reduction mastectomy, the rest of the breast is reconstructed.
Yeah. So basically, deciding which pedicle you want to use based upon the presence of the tumor, so you can have an aesthetically, correct breast at the end of it, right? Okay.
Yes, sir.
Milan, anything else you want to do?
Sir, I would, Sandeep sir,
Yeah.
just a moment. Yeah,
Uh-huh.
Dr. Madhavi, now you understand why Dr. Milind had asked you that question. Milind sir had asked you what cup size is the size of the breast on the other side. What is the
Yes,
cup
sir.
size? Yeah, why? Now you understand?
Yes, sir. Um, uh, in case of oncoplastic surgery, there will be a reduction in the cup size, and hence um, sorry, sir. I didn't get why. I didn't understand that, sir.
Because that decides what technique you want to use for the reconstruction. Okay, whether you're going to reduce the size or keep the size, and if you're going to reduce, to what size you're going to reduce it. Because every reconstructive technique has got its limits as to how much tissue you can transfer, or how much uh, uh, the tissue you can add, or an implant you can add, right?
Yes, sir. Thank you, sir.
Yeah.
Okay, sir.
Okay, so to conclude this case, one thing for so many trainees who are also fresh graduates who are tuned into this nice webinar is that we often get called in by the oncosurgeon to do these cases, and often we don't have the luxury of having a good discussion with the patient, and that actually leads to suboptimal outcomes, not in terms of surgery, because we've done a good surgery, so the free flap is viable and healthy, or the pedicle flap is well inset and healthy and healed well by primary intention. That's good, but the patient is not happy because there's a lopsided breast or a mismatch, or it doesn't make that patient feel again comfortable, to kind of blend back into society. So that's why discussing with the patient as to her needs, her expectations, and matching it to our abilities and our outcomes is very important. So we have to, at some stage, take charge and make sure that that gap is not there, because otherwise it gives the procedure and the specialty, in spite of having doing so much good effort and doing such nice heroic surgery, we still don't get the kudos which may be due. Okay.
Okay, sir.
Yeah. All right. Dr. Sandeep, you want to move on to the next or anything else with this case?
Yeah, yeah. Dr. Madhavi, you have presented quite well. Just one small question, Madhavi. Why did you select? You said you will select the internal mammary. Why not the lateral what do you call it, thoracodorsal?
Sir, it's a case of MRM. I'm not sure of
Yeah,
the viability of the latissimus dorsi pedicle. Sorry, thoracodorsal pedicle. And furthermore, I would also like to preserve that for in case of a second plan, or so I would not like to use the LD pedicle immediately.
yeah. And then and another important thing is, no, if you are actually going for the thoracodorsal, what happens is the breast tends to actually move slightly laterally. Okay, whereas so then the cleft would not be that good. But if you are using the internal mammary, you tend to have a much better symmetry you get attain. So that is one thing. But the problem with doing an internal mammary is that it's slightly more tricky to do the anastomosis because of the chest movement. When you're actually doing the anastomosis, microanastomosis, because you're doing it under high magnification, because of the movement of the chest, it could keep going in and out of focus also. Okay.
Yeah, okay.
Very well done, Madhavi.
Thank
Yeah,
you.
presented. Thank you.
Well done, Madhavi, and all the best.
Thank you, sir. Thanks.